Good afternoon. I see many familiar faces, so I won't bore you with a lengthy introduction. Thank you for coming back for this session on bullying in healthcare, a patient safety issue. I think I see one or two new faces, so I'll go and introduce myself again. My name is Christy Beck. I'm from Ohio University, and I'm a past president of the National Communication Association. And we are honored to be here with you today to share information from our research about bullying and how it might be relevant and useful to you and your organization. For this last session, I'm honored to introduce two presenters. We have with us today Heather Carmack. She is an associate professor of health communication at the University of Alabama, specializing in communication and patient safety. And Roxana Ahmad is an associate professor in the Department of Communication at the University of Albany SUNY, specializing in health communication and cultural competence in clinical contexts. So I will go ahead and turn it over to them. Roxana and Heather.
Great. I'm hoping this little microphone is picking up for you. So you've heard a lot today, for those of you that have attended a number of different sessions, about the wide array related to issues of bullying in the workplace, bullying in children. Today we're going to be focusing specifically on what it's like to be a healthcare worker and experiencing bullying in the healthcare sector. So if I can get, sorry, we had a couple people stand up, everyone from here over to stand up. You're like, why did I sit on this side? So this represents, in any given healthcare facility, the number of people who are currently bullied. Approximately or over 50% of healthcare workers have experienced some kind of bullying in the workplace, be it verbal bullying, etc. All right, 3 of you can sit down. The other 3 have to stay standing. These people make up approximately 21%. And these are the people in healthcare who are not only experiencing verbal bullying, but who are also experiencing physical attacks, either from their other healthcare coworkers or from patients themselves. You can sit down. In a small room, that seems like a bigger deal, right? Less people. So the numbers seem much more stark. But it helps you realize that in healthcare, bullying is incredibly pervasive. So pervasive, in fact, that OSHA has decided that working in hospitals, is the #1 most dangerous industry to work in because of bullying. That's exactly the face we were hoping for. When you think about it, it's quite shocking to realize that you are currently situated in an industry that not only has a lot of bullying, but has created a space where bullying runs so rampant that we can't do anything about it. Today, we're going to be talking a little bit about the specifics related to bullying in healthcare, and then talk about some specific strategies before we do a little performance to get you to think about how to apply those.
Okay, good afternoon, everyone. So throughout the day, you have had a chance to learn a lot about bullying in different contexts, and have also identified, had a chance to recognize, appreciate, and identify what bullying is and differentiate bullying from harassment and whatnot. So what I'm going to do in the next set of slides, just recap what we have been talking about and putting that in the context of healthcare. So usually, we're going to talk about, focus a little bit on horizontal and also known as lateral bullying, mainly in the context of nursing. So it is also known as lateral violence, and it's actually a significant problem in healthcare, especially in the context of nursing profession, unfortunately. Now, it is a deliberate and harmful behavior demonstrated in the workplace by one employee to another. And so far, we have been discussing some of the characteristics. So it would include overt or covert psychological abuse, including gossiping, targeted personal jokes, ostracism, insults, unwarranted criticism, belittling, or verbal aggression. So it is very much identified and demonstrated through those communicative behavior. It also includes sabotage, scheduling, excessive workload. So as I said, it's from one employee to another. And in this case, probably you can see that it is probably done from a superior to a subordinate. With whatever intention that superior might have, but would be demonstrated through these communicative activities. Oftentimes provide the junior or the subordinate with misinformation, misrepresenting information when that employee is probably a new worker in the healthcare sector. Loss of records, a violation of privacy, so eavesdropping, and spreading rumors, and also breach of confidentiality. So research has agreed upon those communicative acts as lateral violence in the nursing profession. We're also going to talk about patient and bullying in healthcare done by patients and families, because oftentimes it's just not the one employee from another employee. It's unfortunately the healthcare providers are vulnerable to the other actors in the healthcare sector. So these would be demonstrated through communicative acts such as demands. So it could be demands for tests, drugs. So really putting excessive demands on the healthcare providers to do these things. Threats to also get providers fired. So oftentimes it will be communicated in oral language such as, I'm going to report you. And then we also, so far talked about the lawsuits, yelling and aggressive posturing. So it will also be supplemented by nonverbal behavior. And oftentimes, unfortunately, result in physical intimidation and physical violence. And a lot of times, research would mostly we focus on the patient's experience, but oftentimes we also see that in the doctor's office or in the experience of nursing, from the experience of nursing professionals, that in their offices, oftentimes patients and their families would engage in these behaviors, and oftentimes they would be termed as difficult patients and families. So why is this happening? Organizational culture of acceptance. So eating their young is unfortunately an accepted culture phenomenon, and it means that bullying is accepted part of nursing. So we are focusing a little bit on nursing because, as I said in the beginning, that this is a significant problem. And what happens is, in the beginning, I gave you examples of the superior and the subordinate relationship, and oftentimes it's also a rite of passage. So then superiors would be thinking that we had to go through the same environment, so it is okay for our subordinates to experience that, or they deserve it. So that kind of mentality. And in the later part of the our presentation, we will talk about some of the strategies on how to deal with it. Also, underreporting culture. And so far in the previous presentations, you have learned about how, in the absence of proper policies or lack of mechanisms, or even just the embedded culture, the institutional history, you would have healthcare providers, workers, either superiors, subordinates, not knowing how to communicate these experiences to the administrative staff. Also, the fear of being reprimanded and counterattack. So far, you have heard about that. And also the leadership and management style, our previous presenters talked about in greater length. So oftentimes what happens is there's a misconception that appearing tough being really a fearless boss would be perceived as an effective superior in the workplace. So, and other times research also has shown that the stigma attached to being a weak leader, not being able to act according to the organization's expectations. So these are some of the perception-based conditions that would lead to bullying behavior in healthcare providers. So why is this happening in terms of patients and families? We know this concept of consumer mentality. So healthcare, unfortunately, is also oftentimes looked at as a consumer-driven business. So buying or selling healthcare, that kind of mentality would result in patients and their families abusing the healthcare providers. And we also talked about no mechanisms for reporting in the absence of proper policies, or oftentimes not having to discuss or disclose these experiences in the workplace. Stress is actually an important concept that oftentimes is not talked about, and this stress could be an experience of the healthcare provider who is engaging in the bullying behavior because of workplace stress, burnout. They would be lashing out. Especially what happens is that you tend to lash out on your junior, but at the same time, this stress could be an experience of the patients and their families, especially the lay caregivers, and then it works in a vicious cycle.
So what happens, right? What are these actual outcomes? And one of the reasons why bullying is considered a patient safety issue, right? We heard earlier that the CDC has identified it as a public health care issue. But when you work in a healthcare facility, it's a patient safety issue. It's about the patient care. But we know that as people who provide care to others, that it's going to trickle down, right? For those of you that have been to, I think some of you have been to all the sessions today, you've heard that whole point of trickle down. So when it comes to patient outcomes, there's kind of uneven understanding of the impact of bullying on patients. We do know, however, if I can get the clicker to work, maybe, there it goes, that the two primary that we tend to think about are medical errors and then, of course, patient mortality. I don't probably have to tell anybody here who works here in healthcare that medical errors are a huge problem in the healthcare industry. It's currently the third leading cause of death in the United States. Approximately 350,000 patients die every year as a result of a medical error. That's more than breast cancer, HIV/AIDS, and car accidents combined. If we add into the mix that it's possibly happening because a provider feels bullied and they can no longer provide the care that they need to their patient, that puts an additional stress load onto the healthcare provider. Tied with that, because not everyone passes away from a medical error, patient mortality is a separate subsection of that. But if we're going to talk about stress in a minute, if you're being bullied and then you have to deal with the impact of knowing that you, say, a patient died, or stories that I've heard because I study medical errors of providers who have accidentally blinded patients or caused them to lose limbs or leave retained sponges inside, right? That's an extra level of stress that you're now dealing with the bullying and that. All of that combined suggests that it has a negative impact on provider well-being. That's not surprising, I don't think, to anyone here. The literature, as I said, has been mixed. As of right now, there isn't a concrete connection between medical errors and bullying. All the literature says is that people believe, healthcare providers believe that bullying contributes to medical errors. Dr. Mills and I are currently working on a study, which maybe we'll come back for, fingers crossed, that is trying to directly talk to providers about if they feel they're being bullied, how it actually impacts their patients and their ability to provide patient care. But on top of that, you can see that all of that patient outcome is going to have that negative impact of well-being. You've already seen the slides, for those of you that were here earlier, that talked about issues of depression and anxiety. But we also know that healthcare providers tend to have the highest rates of suicide, tend to have the highest rates of divorce, tend to have the highest rates of depression, and if you're in anesthesiology, the highest rates of drug abuse. That's a lot to put on healthcare providers on top of being bullied, right? So it's not even just a cascading effect in terms of the bullying happening, it's this impressive layering that happens. So we know then, of course, that it's going to have some work outcomes too. You heard a little bit about those, but in terms of healthcare, what it means for us is, of course, that it's the morale. For those of you, anyone here who works on the floor, directly works on the floor maybe, on any floor, any service? Couple of you, right? One person can impact the entire group. We want to have good work cohesion. And when one person is bullying another, the entire cohesion of the unit potentially crumbles. And now we're having to deal with a morale issue. People aren't excited about, I mean, maybe not anyone's excited to come to work, but you're not ready to come to work. You're not prepared to come to work. In healthcare, the absentee issue is a little bit more intense than in other places. The current numbers suggest that for the healthcare sector, it costs absentee $84 billion a year to replace, like when someone is out, because we're talking about medical temporary workers, right? It's a highly specialized skill. We can't just hope that no one comes in that day and like somebody else just picks up the load. Right, that's how stress and burnout happens. If you ask the other people on a unit to pick up the slack, now they're treating a lot more patients and seeing a lot more care, and that's stressful. But if you currently work on the service, if you're a healthcare provider, you know that maybe you're lucky if you have a floater, but then if that floater's never been on your service, you're going to have to train them, you're going to have to get them up and ready. But most of the time, we're going to turn to medical temporary workers, and those are expensive if you're on the budgeting side of that, because they have such specialized work. Retention then becomes a problem. We heard about that, 77% of people leaving. That's true of the healthcare industry. To replace one healthcare worker, it costs between $50,000 and $103,000. That's not their salary, just to do the job search for one person. If you have an entire unit that becomes just pushed out, now you have to replace all of those people. That's a lot of money, right? You're probably wondering, I understand now why we maybe haven't hired anyone recently. It's a huge endeavor, right? So we've got the absentee numbers, which are a problem, the retention numbers, and as we already pointed out, we know that healthcare is a business, and that means the bottom line is impacted here. So in the end, that's how we often see financial costs go up. Maybe that gets passed on to our patients. Maybe that gets passed on to, just how much something costs in the gift shop. But if we don't think even that gets passed on to the patients, we're wrong, right? Because who goes to the gift shop the most? Not a trick question. Who goes to the gift shop the most? Patients' families, people visiting patients. So inevitably, it still gets passed down to them. You have to hear about it as healthcare providers, because we know that healthcare providers, especially nurses and PAs, nurse practitioners, residents, they're the ones who hear the complaints the most. And unfortunately, if you happen to work the front desk, right, those are the people who hear it the most. So then it becomes a vicious cycle coming back here. So we've got all of these things really impacting healthcare and impacting patient care. And if you're a healthcare organization who, as everyone is, strives to have patient-centered care, strives to have patient safety as one of their key missions, it becomes really difficult to do. So how do we deal with it? There are different ways to deal with it if we're talking about dealing with your coworkers and superiors, and then different ways to deal with patients. Some of these things you've already heard, but it's really important when it comes to a patient safety perspective that we really contextualize a lot of the strategies that you've heard today, as well as what we're going to talk about, because it's different, right? It's not just about going to talk to HR. There are specific historical parts of growing up in medicine, growing up in nursing that actually do impact that. So, and this one's really tough, but we're going to start tough at the top. We have to find some way to create an organizationally just culture. Right? So it's not enough now to create a culture of patient safety, if you're familiar with that language. Now it's about creating an organizationally just culture, because an organizationally just culture says it's about patient safety, but it's also about the healthcare worker. If you think about it, the organizational approach to patient safety just puts that onus on the patient, and they are important. But so are the workers, so are the healthcare providers. An organizationally just culture says that we consider everyone in the healthcare experience. That's how we get it to become patient safety. We also have to really pay attention, as we talked about before, we're not going to belabor that, all of those bullying behaviors. Knowing that when it comes to healthcare, things like, knowing that people are taught to come up throughout their education that bullying is acceptable, that hierarchical difference is not only common, but expected, right? Those are the types of things we're going to have to get past. So for those of you that were just in the last session, think about the last scenario we had with Dr. Berater. How many of you, when you were sitting in that session thinking, well, what we probably really needed to do is, if we really wanted to address Dr. Berater's experience, was go back to his educational experience and tell him that it's not okay to bully the nurses in his clinical practice, right? If we're just addressing it then, it's too late, right? We have to step back and realize that some of those gaps might just be stop gaps, and that we're going to have to address a larger cultural issue, like creating a just culture. You can, if possible, separate yourself from the bully. In that case, especially if, say, you're a floater, maybe try not to be on that particular service. But it's tough, right? In that case, it may just be, hey, you know what? I need to walk away for a second. You can, as healthcare providers, always use the excuse of, I need to go check on a patient. Leave the situation, right? The patient always needs to be checked on, though. So I used to work in a hospital, and someone always needed to be checked on, right? So you could always go and check on a patient. With that said, though, that's a tiny momentary stop just from that instance, because you can't just keep walking away the whole time. Otherwise, the bullying will continue. Instead, after you've stepped away, you either need to go to HR. Well, you do need to go to HR. As we talked about before, right, unless you have some kind of organizational mechanism in place, always go to HR. In part because I think someone sitting here earlier said that they were taught that you always need to document everything. I want to say it was you and you over here, right? That is so crucial, because if in the end you have to build a bullying case, they're going to have all that documentation. I'll give you an example of something that I witnessed at, I won't say the organization, I was about to say it, that's probably really bad. It was a patient safety organization, we'll leave it at that. And a lot of the subordinates were feeling bullied by one of the leaders of the organization who was an MD. They compiled over the span of a year and a half 92 single-space page document of bullying instances, ranging from just the way that she talked about things to physically slapping somebody. I mean, it was on the hand. I mean, that's not bad. That's not good either. But on the hand when they reached for a paper that was theirs and she smacked their hand, to saying things like a man had leaned down to pick up some papers and she said, that's exactly where you need to be, on your knees, right? They documented for a year and a half all of those things and took it to HR because they felt that if they didn't have that documentation, that nothing would happen. So the recommendation of document, that cannot be stressed enough. Because unfortunately, we do live in this climate of he said, she said, and if it happens in private, we might not see it. But if you have evidence that it is over time, right, that going back to that original definition of bullying, we can truly understand how that really comes into being. So know what the organizational codes are, know how you have to do it, and as we talked about earlier, you may not be the person being bullied, but you can step forward. Don't just be a bystander, be an upstander. Now, that comes with a caveat, because I know that that can be difficult in healthcare organizations, especially if it's, say, someone who hierarchically is above you, right? Those organizational structures in healthcare are important and really operate in a specific way. So that may mean being an advocate on a subtler level, not just calling someone out because you see bullying behavior, but helping them, say, put together that 92-page document, i.e. that's what I did. Right? Had to proofread that thing. Somebody had to proofread that thing. All right, so the next set of strategies is a little bit more challenging. How many of you have, for those of you who are healthcare providers who've dealt with patients, have felt bullied by patients or their families? What happened? What happened? Sorry, that's what happens when you raise your hand. What happened?
Well, I mean, there's different examples. I mean, you can be bullied with physically violent people, whether it be family members or patients themselves. There's that too. But, you know, I think I used to work in a trauma center, and a lot of times the families of the trauma patients would, you know, they were so out of control in everything in their life. The only thing they could control was the nurse.
Yep.
Right? And so there was rude behavior, there was aggressive behavior, so but it was a response to their situation as well, right?
Exactly, right. It's a very vulnerable, stressful experience.
Or I took care of a whole family of lawyers.
That's dangerous.
That was really bordered on bullying behavior. They're documenting every motion that a nurse made when they entered the room. It was very intimidating and meant to intimidate.
Were they probably threatening you with suing you with malpractice on the off chance that you
within
did something
5.
wrong?
Within 5,
Oh, sure.
right?
Probably wasn't even that subtle.
Yeah, it wasn't that subtle.
You raised your hand too that you've experienced.
One particular instance that came to mind was I shouldn't judge, but he was a deadbeat dad that a little boy got sick and was on ECMO. The dad showed up in the picture, and we weren't doing enough to help his son. And I just backed into a corner and knew that I was going to have to fight my way out because no one could hear me yell for
Wow.
help. But yet, I've got to go through this man and through the ECMO pump. So then, hence, I'll probably kill his son and try to defend myself. And so I allowed him to
Get right in your face and yell at you.
verbally assault me, and hoping that he'd cool off enough to get space to go out to get help.
I think a lot of times the organizational culture suggests that that's what we're supposed to do when it comes to patients or their families. That when we know that they're in a very vulnerable spot and we know that it's very difficult and that we should just let them vent or let them kind of get all of that out and really only stop it when, like I've seen patients spit at providers and try to bite providers, right? That the line is supposed to be the physical violence, and it's not. Right? And the downside with patient bullying or patient or family bullying is that it might only happen once, but if you see a patient long term, that might become an issue, right? So it becomes more and more. So probably some of the things that we've talked about that work here, continuing from what we've done before, right, is to really clearly, if you can, establish those boundaries. Letting them know that you are here to help the patient, and that you are more than willing to listen to what they have to say, but that we know it's stressful, that we need to be able to do it in a really nice, responsible way, right? Maybe that means tears, and that's okay, right? We know that anger is just that emotion that they're expressing because they're scared, because they're frustrated, or maybe in that case, who knows why. Maybe he was scared, maybe he was frustrated, maybe he thought for some reason he knew better. And the downside of the internet is, right, thanks to Google, I can find so many things and I can become my own healthcare provider, which then becomes a challenge, right? If as healthcare providers you push back and say, well, just because you found it on WebMD doesn't mean that it's correct, right? How are we going to actually deal with that? And part of that is establishing those boundaries if you can. This works a little bit better if you're, say, in a private practice clinical setting where you can more clearly do that. If you're engaging in, say, if you're in the trauma center or the ED, it's really hard to do that when things are just happening so fast. If you can, though, do that. But really the best thing to do, especially if a patient or a family member is coming at you, is to try to de-escalate that situation so that it doesn't get to the point where it might become violent or where you might become fearful of what's going to happen. I think that your story is such a good example of that, where you were really worried about what was going to happen, not only to you, but to the patient too. Right? You were worried that the patient was going to die.
I was twice his size, but I just knew by my actions there was only like a foot of the pump, and then if the dad falls over the pump, he'll become disconnected and there'll be blood everywhere. It's not going to be good.
But we've had examples here of, a parent of a repeat patient that was coming a lot, that was very aggressive.
Sure.
Where in fact staff verbalized that they felt threatened for their own personal safety, and so I mean very real.
It is.
Was this person, was in that instance, was that person not allowed to come to the facility anymore? Or was
Yeah,
it
it got very convoluted.
Good question.
There were some barriers, there were some,
Yep.
yeah, it was a challenging situation. And even that was organizationally difficult, because there were people that thought very clearly this is what should happen. There was, you know, there was this piece of it. It was pretty complicated. But staff truly felt threatened and vulnerable, and that has to be addressed, so.
And it's kind of one of those hidden things that no one talks about unless you're working with patients and you see it happen. If it happens to you firsthand, or you see it happen, you're like, what in the world just happened right now, right? Quick question for you. We know that Shriners has a policy about organizational bullying. Do they have a policy in place related to what happens when families or patients engage in that? Is part of, I guess the question is, part of it became convoluted because there wasn't a clear policy in place.
Yeah, well, so we actually do have a workplace violence policy, which I'm gonna go back and read when the workshop is over, to see how clearly it does address things, and then maybe share that widely, or fix it, right?
Or fix it.
Right, because I'm like, hi, yeah, we got something, but I don't know exactly what it says, so.
Well, if it's not, right, that's a great recommendation, is find some way to create a very clear policy about reporting with patients. And it's not to get them in trouble, but it's to protect your safety, right? If it's a just culture, patient safety is about you as providers too. And that can't happen if you don't feel that there's a mechanism in place to communicate that. And that goes from everyone who sees a patient, whether or not they're providing care or providing food, right? It's for everybody. Because I know I've been in hospitals where I've seen the people delivering the food just be berated about, you know, and like trays flipped up, and you're like, what happened, right? And it can be something as simple as like maybe they didn't want that food, or they didn't like it, or, you know, because again, it's, you know, as you know, it's a very stressful situation to be seeking health care.
I mean, I do know that we've had issues like with, like drugged out family members or whatever, and, you know, where in fact, it is perfectly great to go ahead and pull in law enforcement and pull in whatever safety support you need to manage that situation.
Exactly.
So.
The question is, when does that need to happen? So right there, right? If it happens, contact security. Right? I think sometimes maybe people are a little hesitant to do that. Either we feel like, oh, we do it too much or we don't do it enough. But if you ever feel personally threatened, once you get out of the room, contact security to help deal with that. All right, so now that we've talked about some of the specifics here, thinking about your own experiences as healthcare providers, let's do a little scenario. We're going to do something a little bit different, though. Oh, yeah.
I wanted to, if it's okay, because we have time, right?
Do we? I have no idea. I was looking at the clock. I don't know.
I think we are okay. Like, how much time do we have?
Yeah, till 5, and that clock is
Okay, yeah. So.
Okay,
we should
good.
make
It is
about an
accurate
hour,
now.
Yes, because as you are discussing some of the facts and I guess the problematizing the issues, I was taking notes, and I think. It's not so black and white. You know, we have been talking about, okay, changing the organizational culture, go and, you know, call the security. But we have to also realize, not, you know, be in denial that it's not just that easy, not so black and white. So oftentimes, you know, I think I did mention and I think the concept of impression management is also important. Because oftentimes it's, you know, when you work in an organization, especially either you're, you know, you're a new employee, you want to really make an impression, like a first good impression. And not just because you're vulnerable and you really need this job, it also comes with, you know, our own personalities, that I will just, you know, tackle any situation. So there's this psychosocial factor too. And then there is also on the part of the superior, being a tough leader, being the you know, like a tough boss, having to you know, maintain the kind of impression, the perception that, you know, he or she has developed over the course of time, be it, you know, the institutional history, not having proper culturally sensitive or appropriate training in med school or nursing school. So those are some of the things we have to think about. And also the larger environment, the systemic issues. healthcare organizations are conflict zones. We already know this. And I think listening to the problem family you were talking about, or the stress, and a lot of this stress is, yes, it's a stressful workplace environment. People are, because it's people's health, right? So it's life and death, it's your loved ones, and it's a job, but also what's happening in the current, environment that we live in. And a lot of these things are beyond our control. And that's why, we mentioned the organizationally just culture, because it takes into account share accountability. So it's also, I guess, we have a larger role in terms of not just, okay, yes, we educate our workers, but I think patient education is also important with patient safety. So we always talk about, okay, communication skills training providers, but also these issues. And for these issues to take place, we need resources. So we need to develop partnership. And so, just sort of like trying to think about it. And I think instead of solving and bringing in new problems, but these are important issues, and especially for many of you who are sitting over there, because you are in leadership positions. And also, you might be in the superior-subordinate relationship. So I thought these are some of the important issues that we need to be thinking about and not denying. And from a communication perspective, I think a supportive communication climate is really important. And that's something that probably won't require tangible resources. That's something with sensitivity and a little awareness. We can work together. And it's all part of that organizationally just culture that we have been talking about. Okay, so the scenario. So it's almost the end of the day, and some of you, I know we have been here since,
very early.
Very, very early. Yeah, exactly. Yes, but thank you for hospitality.
You also been here very early.
Yes, yeah, it's okay. But some of you have been, very studiously, religiously attending our session, so we are very thankful. And I think that, we have sort of, Heather and I, we thought about doing something really fun. And she did mention, I'm sorry, I have a bad tendency, I'm
Maybe
sorry.
you should have had this
Yes,
one.
exactly, yes. A little performance. So, what we will do, I think we can put you in this scenario. We have 3 characters. One, the 4th character is actually someone who is not actively involved in this scenario. So if we can have you work in groups of 3. So I think there will be just one person left. So it could be a group of 4. That would be great. So what we would like you to do is, can you read? We actually didn't prepare a handout, so okay. And we can also read it out loud for you. Just in your group of 3, and there will be one group of 4, please discuss. But we don't want you to we're not gonna eavesdrop and go and try to sort of understand what you're discussing, or not ask you to share in a larger group, but we will actually ask for one volunteer group, because in the interest of time, we would have loved to see everyone perform. One group who are really eager to come up and role play. So you'll really have to do it, because it's the end last session, and we talked about putting theory into practice. And oftentimes, we don't talk about, I think one of the first things especially from a communicative perspective, saying things out loud, like seeing is believing, so uttering makes a sense. So you can hear yourself and get to, wrestle with the issues in front of your colleague. I think that's a great first step. And in terms of identifying and whatnot. So without talking any further, please, in your group of 3 and one group of 4, let's spend no more than maybe 10 minutes just thinking about it, because it's nothing, we didn't present anything new. Throughout the day we have been talking about these issues, but we want to really see you perform. Okay, great, thanks. Do we have one group? that is dying to perform.
She was killing me.
Trust me, we're not going to give you Oscars. Yes, so you can.
You know, if you weren't videotaping it, we'd go, but we're camera shy.
Are they?
Oh, please.
I'm not here.
Steve's been on,
What are you, camera shy?
It doesn't work.
It doesn't work.
Okay.
All right.
Then,
Awesome.
can you? Yeah. You would need to. Okay.
Yeah, here we go. The volunteers. Okay, so it'll be slightly awkward because you have to stand close to me with the mic. So I'm gonna sort of, well, they said to not undo this, but I'm gonna undo it. Hold the mic kind of around you all so they can hear you.
So this is Joanne.
Joe.
This is Joanne.
Yes, so identify
Joe.
yourself.
And I'm Belinda. And I'm Cheryl.
Okay. Oops. Yeah, you have to speak loud.
Cheryl. And so Joe is our preceptor. We're orienting with him.
Awesome.
Joe, there's an order here to go put in an NG tube, and I've never actually put in an NG tube in a real patient, and I don't know what to do.
Well, I don't have time to help you. Who are you gonna find?
Well, who do I find? Because I've never done it.
Ask Cheryl.
Have you ever done it?
No, I have never done it. We could just use some help, like, you know, we're kind of new and, you know, just once, like, just so that we can make sure we don't hurt the patient. Like, you know, because we haven't either, none of us have really done it. And I know you're busy, but, you know, and,
They never taught you that in nursing school?
yeah. So, yeah, we learned it, but, you know, just didn't get the, I didn't get the
I'm gonna go
oppor-
get this stuff.
I didn't get the opportunity, you know, to really do it. I wish I would have.
Mhm.
Just could you help us for a minute? Because the patient, you know, we need to get it done because the doctor ordered it.
I have to do everything around here. Let's go.
Yeah, who knew there were gonna be props?
Hey, what a performance! Yes,
Right.
indeed. We should have thought about some gifts.
We should have.
Yes, yeah.
All right. So, oh no, go
Yeah,
ahead.
no,
Oh.
quickly, I'll just recap, I
Yep.
guess.
Yeah. So you're going to be answering questions about if you were Rebecca, how would you handle this situation? Go ahead. Sorry.
Yes, no, that's okay. Yeah.
Oh, yeah.
Do you want us to give you feedback now?
Yes, please.
Okay.
Yes.
As Rebecca?
Yes.
So obviously listening to what both Cheryl and Melinda have to say and empathizing with what they're saying, but also communicating with them, you want to talk to Joanne and potentially suggest having a meeting with everybody together so that everybody gets a chance to communicate openly and hear what the other has to say and then decide how they want to proceed from there. I'm not talking to her. Maybe more.
Anymore.
Okay. I know Melinda and Cheryl are really kind of low on this one. You did look scared. You did look scared.
So you would go with opening the floor for
I would
free flow?
probably talk to Joanne too separately
Okay.
first, and then if everybody was amenable to meeting.
And why would you talk to Joanne separately? What would that accomplish?
To know her perspective,
Okay.
and to see if maybe she has additional stress going on in another part of her life.
Yes.
Just to better understand maybe why this behavior is occurring.
Exactly.
And not to act as an accusatory, like aggressive.
Right.
Like, why are
They're
you?
even aware that their behavior
Yeah.
was as
Yeah.
intimidating
Ask that
as
question.
it
Yes.
Mhm.
Yes. So the overall communication environment. Yes. Okay. Any other group? Any other suggestion you would have? Recommendation? Yes, please.
So I would first get facts and kind of get actual scenarios that happened. So then when I meet with Joanne, I can bring that to her and say, this was the the situation, this is how it was felt, and then maybe get her side as well.
So you would probably need to advise either when they start as new employees or as this is happening, Melinda and Cheryl, to document everything. And we have been talking about that in order for you to get the facts, right?
I think there's a starting place though, where
Yeah.
there is a piece where when you brought a new story, you do have to assume some good intent or that you don't have facts. I mean, you
Right.
have to go out and investigate. You have to decide that, it's not necessarily assumed that Joanne is a bully. I mean, you have to start at the beginning before, I do think sometimes it's a step that we miss where then you have people like documenting, but nobody has ever said to Joanne, you can't do this,
Okay.
right? You need to, if you're precepting somebody, this is your accountability to actually demonstrate and walk them through. I mean, make sure that that they're aware that their behavior
Right.
isn't.
Trying to make changes to that embedded institutional history of, well, this is the way it always has been, and that's just what's supposed to happen.
Well, I just think approaching Joanne or Joe with like a curiosity, rather than having a preconceived idea. And I think that's hard to sometimes remember when you are feeling empathic or maybe even feel a situation you may have been in the past, like to remain neutral until you do gather some good information.
I think too that maybe there could have been there was a reason behind having Joanne be a preceptor, but maybe it wasn't thought out too. And she was forced to do something that maybe she wasn't comfortable to do or didn't have time to do or want to do.
Doesn't feel comfortable working with new nurses. Yeah.
And also based on your performance. I mean, I was paying attention to the nonverbals. You were really playing, I know we decided not to call victim, but the target, kind of like the like behavior. You were doing this and that, so I don't know whether we should be paying attention to that. So sort of, we talk about perpetuating, right? Helping to continue in that vicious cycle and environment. And I guess from a communication perspective, oftentimes, and it's part of the education, having a really confident posture sometimes help, in terms of standing up. And oftentimes, they can go a long way beyond words, right? So giving the coworker an impression that that's not how you can behave with me. So,
Yeah, Carol.
I was gonna say, I think that's one of the really important things that comes out of the research is that oftentimes within nursing, people get promoted into preceptor or manager positions based on their technical skills and not on their managerial skills or their leadership abilities. And that becomes incredibly problematic because that's kind of the career path, but not necessarily the supported career path. And so there's very little leadership training or even kind of sorting out to figure, does that even meet their skill level before they go down that path. And so if it doesn't meet their skill level and they're not getting the training, that can be a double whammy.
And sometimes, especially in a small environment, logistically,
You're
there's
you're
only
it.
X number of bodies available, and you're picking from the warm body that you have, right? It's unfortunate, but it's real.
And depending on the type of education or schooling, depending on the type of education or schooling you received, you're lucky if there was a chapter in one of your textbooks about leadership. Or my personal favorite, a whole chapter on communication. Just the one. Right? And now you're like, great, now I have to be a leader. I don't have any of that background.
yes.
Oh, sorry, I'm not in charge of this. I'm sorry. We're just pointing out.
The long-term effect with this is those two brand new nurses, if they're not mentored well, they're not received well, they'll leave nursing altogether. And we're in a huge crisis as it is.
Yeah.
But I think the culture needs to change of how we interact with our new nurses so that we can grow them to be great nurses and experienced and not lose them.
Right.
Because in the literature now it says
It's
that they
more,
will leave
yeah.
nursing altogether.
Right.
And that doesn't help us at all.
Yeah.
Yeah, right now it's what they'll stay essentially that 5-year mark is the mark that they'll decide if they're staying in the profession or not.
Yeah.
I think there also, or at least something that I've encountered fairly recently in my position is you can have a seasoned nurse who's a different generation, different ideals, and then you hire someone that's brand new out of school. They sometimes don't mesh because of different ideas or thoughts about how life is or experience. And so you have to look at that.
Since we talk about embedded institutional history and deeply entrenched sort of attitude and also perceptions, one thing that could be considered is, in oftentimes I think in education sector, you have this teacher's trainee, so trainer of the trainee. So for seasoned nurses who probably with the changing environment and times and a more diverse and diversified workforce, there could be training for seasoned employee superiors too, how to deal with the changing environment and new issues and whatnot. Again, these things would require, of course, a lot of creativity and resources, but something to think about. The second scenario.
Yeah, so this one, sorry, is going to hit a little close to home for you. Sorry about that. If I can get it to go. Here we go. Nope, that's the wrong way. What button am I hitting? There we go. It makes a noise when you hit it. Okay. Here we go. So in this case, we're talking about a provider having an interaction with a patient, or in this case, the patient's family member. As individuals who, I think everyone works here at Shriners is interacting with pediatric patients as well as their parents, you might find yourself in one of these types of situations, and for some of you, you already have. So we're going to do role play again. In this case, what I want you to think about is one person is Sam, one person is the parent, and then the other person is going to be the supervisor or even just a coworker that could maybe help Sam out. So thinking about how are we going to help diffuse this situation before it gets, if you've ever had a patient follow you, it's weird, and they're going into spaces maybe that they're not supposed to be in, period. So thinking about if you're Sam as well as the patient or patient's mother, how are you then as a coworker or a supervisor going to help in and help Sam diffuse this situation? Because clearly it's escalating pretty quickly. So back to your groups, role play a little, and then we'll see who wants to be the second guinea pig. Okay, two groups then. So we've now cut your possibility of coming up front in a third. In a third, sorry guys. You're just trying to up their chances, aren't you?
All right, so I'll be the mom.
Sounds like we're winding down. One of the groups is really, refining their scene, I think. All right, so which group would like to come up and perform this scenario for us?
You're on, we already did ours.
We already did ours. But this is your moment to shine.
Well, we were actually discussing something else, but.
Oh no, I tell my students no. Yep. I don't know. We can even bring the mic to you so you don't even have to come up here. They can just, maybe, can you swivel the camera that far? No, he says no. Okay, you have to come up to the front. I'm sorry. Camera shy. They don't have to do it if they don't want to? Oh, I thought it was on video. Oh. They want to see it. Okay. They left. They ran quickly.
Olson. Am I Sam? Oh, I'm Sam. I'm the nurse practitioner.
Okay. I'm just the mic holder.
Okay. My son is really sick. He's got the flu. Can I get just a prescription for some antibiotics and we'll be on our way?
I need to listen to his lungs.
Oh,
and
he's
to
fine.
his-
I mean, he's not fine. He's got the flu, but you don't need to examine him. I
Yeah.
just need a prescription.
Yeah, well, we need to examine him and make sure and check his vital signs and listen to his heart and his lungs.
I
Make
have
sure.
been here for an hour. I don't have time. He is sick. I've got 4 other kids at home. I just need a prescription.
But we can't just give prescriptions just, for anything. I have to assess him and make sure he's
Let her
okay.
assess you.
Gotta assess
Open your mouth. Gotta get back in character.
Okay, well, and then I need to go just consult and see which antibiotics. Does he have any allergies to antibiotics?
No, he doesn't have any allergies. He just needs an antibiotic.
Sam, how are you feeling today?
Tim, just tell her he's fine. He hasn't been able to eat. Just tell her how you feel, Sam.
I'm sick. Can we just get our antibiotics so I can go home and play Fortnite?
Okay, well, I'm just gonna go consult with the physicians outside.
How
and
long
then
will
we're
this
gonna
take?
talk about
5
what's
minutes?
the best treatment plan for your son.
Okay, 5 minutes.
It may take a bit longer
I
than
have.
that. but we can-
My babysitter's gonna leave my babies. I need to get home. 5 minutes. I've got 5 minutes.
We'll do the best that we can.
Your best is not very good.
All right, Nancy. We won't have her follow you around and get in your face. I did too. I really get in her face, but we won't do that. So you've witnessed this happen, right? And how are we going to maybe come to Sam's aid to help her diffuse the situation, right? We'll pretend that the mother has followed her and is now yelling and really like in her face, threatening her, threatening to sue, threatening to report her. How are we going to step in to help?
I think sometimes there is a place where stepping in is just providing somebody else to assume control of the situation. And so, if you can't de-escalate, sometimes the best thing for the employee that's getting beaten to a pulp is to remove them from the situation and say, let me see if I can help you. What is your needs? What's the problem here? Right? I mean, sometimes you can step in and facilitate. Sometimes you need to just remove Sam, save Sam. Maybe.
Right, somebody's going to have to, if Sam is struggling to diffuse the situation, hopefully someone is going to step in. Maybe it's, hey, is there something I can do to help? Or, hey, Sam, do you need anything I can help you with? Right, really coming in to establish that. Sometimes that also means stepping in and say, you know what, Sam is doing exactly what he or she needs to be doing. We need to talk a little bit about how to speak to the provider, because right now this is not a productive conversation. You yelling at Sam doesn't mean that. Now, that's not necessarily best, right? Because you know that they're probably just going to start yelling and screaming at you now. But sometimes letting people know that, yes, I can tell you're upset from the way that you're speaking to me, right? Like, I want to help you. I can't help you if you're yelling at me. Did I see your hand?
Like, Debbie really asked the part, and I've been in that scenario before where there's no diffusing. That parent is upset. They are out of control, and it doesn't matter what anybody says to them.
It's true.
They are out of control, and so like Debbie said, sometimes you just kind of have to remove everybody from the situation. Try to let them cool down a little bit, and try it again with them in a few minutes. And they might not ever really calm down, and sometimes you just have to go about your job and do the best you can, and say this is what we're going to do, we're not going to do, and then.
Yeah. Especially if Sam doesn't give the script for antibiotics, right?
Well, then you give them the complaint card.
Mhm.
Say, you feel free to voice your concern to this, but it's outside of our professional or medical.
And bullies
Whatever.
usually don't back down. I mean, they keep at it. They don't back down.
I mean, actually, if you look at like with the opioid addiction and stuff,
Yeah.
when they first started in the Instacares or the ambulatory centers and stuff, when they first started, saying, oh, we won't give out oxycodone scripts or whatever, you can imagine how much pushback and how regularly they got that, anger from people who weren't getting what they deliberately came for, right?
That's true. I'll point out, that's actually part of what my job used to be when I worked at a hospital, was whenever we had a patient who came in with a fake script because they wanted oxy or something, I was the person who would come up front to be like, no, we're not, that's a fake script. Our script doesn't have those designs on it. We can't give you a script, or we can't give you a refill on that, because if you've been in that situation, you know, they struggle with those types of things, and someone has to diffuse the situation because they can't stay there begging for a script.
Yeah, so I mean, it becomes helpful when they put in rules that go legally, we are not allowed to provide it.
Yep.
Then the provider has an out, but for something like antibiotics, it's a little tougher, right?
Right, I mean, I could order it off the internet if I really felt like it. But that, right, and things like, and we specifically used antibiotics in that scenario because you probably have encountered a parent who thinks antibiotics are the right treatment for everything. You take them for a few days and you feel great, even if they're not helping you. And some of you, I'm sure a lot of you already know that that particular case might not need antibiotics. They might need an antiviral flu medication. All right, we've got a couple of last takeaways, and then we will get out of your hair for the day. Or not.
Yeah, no, that's fine. Before that, I was just curious, does this hospital have any, and I guess it's part of the takeaway too, written statement anywhere mounted either on the wall or on the table where patients come in, and it would be written that something like that this place has a zero tolerance policy for abuse from or bullying behavior from patients or something.
It's not that specific.
Okay.
There's patient rights and responsibilities.
Okay.
Posted, and the responsibilities do talk about behavior.
Okay.
But not
Okay.
specific
Not to that extent. The reason I say it because I saw it in a dentist office, but that was in Canada, and it was a new development. So, and we have been going there since the past like 11 years, but it was only recently that we saw on the desk that was just, it was not certified or anything, so it's just like really nicely framed, but that did catch my attention. So little things here and there that could be done, I guess, in consultation with the employees here organization. Okay, so to conclude, we are just going to recap what we have been talking about for our presentation, and some of these are also related to the presentations that were done throughout the day. So bullying in healthcare can have a severe impact on patient outcomes, including leading to medical errors. It can be difficult to speak up for yourself, and we talked about having to identify bullying and having to distinguish it from other kinds of behaviors that might not be bullying, and others. So speak up for yourself and others in bullying situations because of issues of hierarchy and fear of counterattack, and oftentimes it's the only job you have. Or the embedded institutional history and whatnot, and also the lack of any written policy or agreed upon rules. You may not be aware of bullying behavior, so be aware of subtle signs of bullying, and so far throughout the day, and also based on the scenarios and your performance, I guess you have a good understanding now. Open and honest communication, we have been emphasizing this a lot, is key to stopping and preventing bullying in healthcare. So having a very supportive communication climate is both beneficial both for the patient and also for the healthcare providers. And if you're being bullied or see others being bullied, you should address the situation up front. So, I'm clearly remember one of my colleagues, it was at a university setting, she would always upfront address any rude behavior that she would experience from any colleague, be it a female colleague, be it a male colleague. And at first, the very beginning, my job, I used to think that she was kind of overreacting. But now, throughout my experience in the workplace, I can see the value of actually not holding any feelings and really letting your interactant who is being a bully that's not okay, or you felt uncomfortable. And we have been talking about how oftentimes the person who is bullying you is probably not aware of how strong he or she might be coming off. So that's very important, and healthcare is no different. And lastly, bullying in healthcare will continue until we create organizationally just cultures. And I think we have been talking about the different components of an organizationally just culture, where all of us who are involved in healthcare, all of the actors, the healthcare providers, the patients, the families, should share the responsibility and accountability. So with that, we end our session. We have a few minutes, I guess, so if you have any questions or comments, we would be happy to receive them.
I don't know if Dr. Beck wants to do a closing statement at
Yes,
all.
of course. Yeah.
Oh, she does.
I do have a question.
Please.
As you mentioned, like health professional curricula
Mm-hmm.
and introducing this concept, do you see that anywhere?
Not yet.
I mean, it's a trend, I hear about it like in nursing, but I'm just
Mhm.
curious.
So that's something that we're beginning to, I guess I'm sort of like talking about it. We're beginning to work out that at the University of Alabama as part of our patient simulation center that we're building. It's going to have a very strong communication curriculum, and that's going to span everything from having difficult having difficult conversations to disclosing medical errors to breaking bad news, all those types of things. And it can include how do you address bullying in the workplace. Right, we currently right now have a beautiful nursing simulation center, but they're booked. It's jam-packed. And the new patient simulation center that we're going to be having will have both live standardized patients, as well as, we're not doing any telemedicine, as well as, hopefully I'm crossing my fingers, we're getting a couple of the standardized dummy patients that we can be communicating, say, like live action things through as well. But the curriculum is something that we're beginning to work on and building because it doesn't exist. That's my grand vision for this. I'm not like officially in charge of this thing, other than communication is heavily involved, is designed to have a heavily involvement with that. So we're going to get there.
Nice to hear, because it is an endemic issue, I think, in curriculum. It's just lacking, and then you transition into the professional role, and it's like, I don't really know how to deal or cope with this, or kind of what to do, and so you kind of muddle your way through it as a new grad, and you keep working, and you get experience, and now, like, we have some experience here sitting in this room, and it's all great, but, like, it would have been nice to have some tools maybe before, right? So, thank you for sharing that.
To piggyback, actually, some of the European countries are making a headway, and it also, you have to, and I think throughout the day we have been talking about the importance of contextualizing this. So maybe, your hospital, and I'm just saying as an example, is not the best case here in terms of having to experience and go through these, but there are certain, I guess, sectors, or I don't know if we should call it a sector, let's say, so like genetic counseling, they actually, in that context, because in genetic counseling you involve not only the healthcare provider and the patient, you involve the whole family, so it becomes a really hot spot. And there are a lot of case studies where, and it's actually out in Denmark, some communication departments and the med schools, they are actually collaborating, and they have huge a volume of transcripts that they're going through to sort of identify. But it all starts, I think the change will come from doing a needs analysis, because it has to be institutionalized, right? Like systemic. So if there's a need from the institution or med school and whatnot, then probably you will, take stock and think about, okay, let's go to the root of the problem. We need to educate, raise awareness. And not just the healthcare providers, I think patient education is also very important because, it's a dyad, right? Communication, and it's even more than that. It's like in consultation, you have a group of people. So, different things, different actors, different situations are involved. So we have to be thinking about that, like holistically more.
Thank you.
No problem.
All right, then we'll close with Dr. Beck.
I just want to thank you all for coming, and hopefully some of the material that we've shared have helped provide you with some communication-based strategies for responding to these really difficult situations, the woman who played the mom has left, but I know I'm a mom, I've got 4 kids. No, I don't think I've ever done that. But I know how difficult it is because, if the person's babysitter is getting ready to leave and she's emotionally charged, and everybody comes from those different places, and all of the employees come from different places. And so trying to navigate these really complex situations are challenging. And so hopefully throughout the day-to-day, we provided some resources of how you might handle some of those situations, how you might diffuse them, how you might engage in institutionalized practices so that you can put a stop to systemic bullying of coworkers and also just really help make this, I love the phrase of the just environment. So anyway, thank you so much for coming. We do have some evaluations. If you'd be kind enough to fill them out, that would be wonderful. But thank you so very, very much. We've enjoyed being here today and we appreciate your hospitality. Thank you.